Next speaker is Liz, and Liz is a speech-language pathologist in rehabilitation of speech language and swallowing disorders in adults. Liz graduated from Northern Arizona University with her master's in science degree and speech-language pathology in 2010. She has worked in a variety of settings, including inpatient and outpatient schools and home health. So Liz, thank you for being here with us.
All right. Thank you for the introduction, Melissa. Can you hear me okay?
Yes, I can. Yes.
Oh, good. Okay. Just get settled here. So before we begin the presentation, I'd just like to take a minute to briefly explain the scope of practice of speech-language pathology. Because we work in a variety of settings, some people are more familiar with maybe an aspect of our work like articulation, maybe a niece or nephew that has a problem with a specific sound. But as Melissa mentioned, our scope of practice covers at least 6 main areas. So we talked about the articulation. We also cover language, both receptive, the language we understand, and our expressive language. The area of cognition, and that includes things like word finding, auditory processing, problem solving, things like that. We also work with patients with voice disorders. Stuttering or fluency is another area. And then also our topic today, swallowing. Let's see. I'm having trouble moving my, oh, here we go. Let's see if that works. There we go. Okay. So I have a fun fact up here that we average, on average, we swallow between 1,200 and 2,000 times a day. So that's a lot. And the point of bringing up a fact like that is as we have a difficulty with swallowing, it's just like any other muscle we use in the body. The more we use it, the better it works for us. So, you know, use it or lose it kind of a thing. So we want to keep those swallowing muscles strong. So let's get started here. It's a pleasure to be with you, and thank you for joining us. As we look at the process for swallowing, there are 4 steps in the normal process, and they can be broken down by 2 voluntary and 2 involuntary. So the voluntary stages include the oral preparatory phase and the oral transit phase, both occurring in the mouth. And the 3rd phase, the pharyngeal phase, is an involuntary process controlled by the brain, specifically in the medulla, in the brainstem. And then our last phase, the esophageal phase, occurs due to the propulsion of the muscles lining the esophagus to move the bolus through to the stomach. So in our first phase, the oral preparatory phase, the problems that we see as speech pathologists in swallowing in this phase include maybe the first one would be the poor labial or lip closure, causing food or liquid to fall out of the oral cavity. The next area we're looking at is chewing, mastication. We'd like to see a nice rotary or lateral movement of the mandible as opposed to an up and down type chewing motion. Another area is pocketing of food caused to reduced buccal tension. So the muscles within the cheeks close off that area to prevent food getting stuck between the gums and the cheeks. And lastly, the inability of the tongue to create a cohesive bolus due to weakness. So the formation of the bolus requires that the tongue create enough pressure against the hard and soft palate that the bolus becomes cohesive. So we're looking here at this diagram, and it's kind of a neon green, and it's located at the top of the tongue, pressed against the palate there. Our second phase, the oral transit phase. So again, you see the cohesive formation of the bolus as the tongue moves the bolus from the anterior to the posterior position in the mouth. You can see with the arrows there. The soft palate, or the uvula, located at the back of the mouth, lifts basically to close off the nasal cavity, preventing nasal regurgitation. And the last step, critical to the next phase of swallowing, is the sensory receptors in the tongue and in the oral pharynx, which send information to the brainstem to trigger the involuntary pharyngeal phase. So before we continue looking at the next phase of swallowing, there are two important protective mechanisms that occur in a normal swallow, and these function to basically protect our airway. So let's locate two tubes pictured in this diagram. The tube near the front of the neck is labeled the trachea, which leads to the lungs. The second tube behind the trachea is the esophagus, leading to the stomach, which is where we want the bolus to go. And above the trachea is the epiglottis, labeled there on the right. And its job during the swallow is to invert, or actually flap over, the entrance of the trachea. And we'll see it do this in the next slide. But the inversion of the epiglottis, it's caused by the anterior movement and elevation of the larynx once the swallowing is triggered. So that's the first protective mechanism. The second is at the level of the vocal folds, and we refer to those often as the vocal cords. And most of us think of the vocal cords as voicing, but they actually have their second job is basically to close off the top of the trachea. So in some patients with Parkinson's, we may see a incoordination or muscle weakness in one or both of these protective mechanisms. So in those cases, we want to perform an evaluation of swallowing so that we can see with imagery where the problem lies. And we'll address this swallowing evaluation a little bit further into the presentation when we talk about the cause of swallowing disorders. But it's just important to note here that trouble often does occur in swallowing when the epiglottis does not invert completely, or if there is any kind of bowing or incomplete closure of the vocal folds. So the third phase here of swallow is called the pharyngeal phase. It's important to note that in the pharyngeal phase of swallow, it's a dynamic process. There are many swallowing mechanisms that happen simultaneously once triggered by the brain, because this again is involuntary. But ultimately what we're seeing here in the diagram is we have the base of the tongue continuing to move the bolus into the pharynx. The bolus then is redirected around the epiglottis, and you can see, as I mentioned in the last slide, the epiglottis is now inverting, and the propulsion of the pharyngeal constrictor muscles are moving the bolus to the entrance of the esophagus in this stage. Our last phase, the esophageal phase, the mechanism here at the top is the upper esophageal sphincter. And basically it relaxes to allow the bolus to pass through the esophagus. At this stage, the vocal folds then open and breathing is reinitiated. And there is a stripping motion of the superior, middle, and inferior pharyngeal constrictors, moving the bolus downward towards the stomach. And the last step in this phase is the relaxation of the lower esophageal sphincter, allowing the bolus to arrive at the stomach. So dysphagia. Dysphagia is a term used to describe a disorder of swallowing, and it occurs when there's a problem with any part of the swallowing process. For example, we talked about weakness in the tongue or cheek muscles, making it hard to move food around in the mouth for chewing. But really an impairment in the function of the palate, the pharynx, the larynx, the vocal folds, the upper esophageal sphincter, or the esophagus can be the cause of dysphagia. Dysphagia can also be caused by a damage to the brain, causing an inability to trigger the swallowing reflex to begin muscle movement that allows food to move from the mouth to the stomach. And our biggest concern with patients who present with dysphagia is aspiration, where bits of food can fall or be pulled into the trachea, resulting in the development of aspiration pneumonia. So in addition to weakness, patients with Parkinson's may be swallowing less often than normal. And you saw in that fun fact, there is a variation to normal, but when we see patients come in swallowing less often, what can often happen is saliva begins to kind of build up and become difficult to manage. In normal swallow, when food begins to travel the wrong direction, our natural process is to cough. And we do this in order to move any food or drink away from the trachea. Frequent coughing and swallowing can be an indicator of muscle weakness or incoordination of the swallowing mechanism. And patients with dysphagia may experience the reverse as well, which is they experience a reduced sensation in their throat or larynx. And in these cases, the patient is not coughing when food or liquid is approaching the trachea, and this makes them an especially higher risk for aspiration and possible onset of pneumonia. Another area of concern is when we see patients who have difficulty swallowing pills. And again, this could be from a different kind of impairment, but sometimes due to a buildup of residue collecting in the larynx, not really traveling through the esophagus or the trachea, but just kind of stuck there and making it difficult when those pills get caught up in that residue. Go now to the treatment of dysphagia. So before we can start treatment, it's important to highlight the importance of a swallowing evaluation. And this must be performed in order to visualize and identify where the problem lies. And there are two avenues for swallowing evaluation. There is the Modified Barium Swallow Study, the MBSS. Basically, we take different consistencies of food and drink and we mix them with barium, and we're basically watching the patient as they swallow those items mixed with barium through X-ray. The second is called the fiber optic endoscopic evaluation of swallow, referred to as FEES. And this involves a very small camera, and it's threaded through the nasal passages and just slightly back down the back of the throat. Not painful, maybe a little uncomfortable, but both of these measures allow us to determine which muscles we really need to target in therapy. So those are important steps to take. Now, swallowing exercises work really well, typically with patients in Parkinson's. And there are a dozen or so exercises that we use to strengthen the muscles responsible for swallowing. And I just wanted to go through a couple of them with you. Maybe one of the more prominent ones is called the effortful swallow, and you're welcome to do this with me. But basically what you're doing is you're creating tension with the extrinsic muscles of your neck. And basically you're swallowing against that resistance. So if you want to kind of push your head forward and get some tension there in your neck, you'll be able to feel it with your fingers there. And then go ahead and swallow against that resistance. Yeah. So that's the effortful swallow. That exercise works to improve the hyoid laryngeal excursion, where the muscles in the larynx raise to allow for greater epiglottic inversion. So that's the purpose of that one. Another exercise is called the flat tongue swallow. And basically you take your tongue and you position it against the roof of your mouth. And while you're holding your tongue in place, you want to swallow without letting your tongue move. So we'll go ahead and try that together. Go ahead and take your tongue, push it against the roof of your mouth, and swallow with it in position there. Yeah, very good. Okay, so that one's a little bit more difficult for some, but that exercise works for tongue strengthening. So in addition to exercise, we also use another tool called neuromuscular electrical stimulation. And this, the purpose is to help recruit both muscle activation and to stimulate the peripheral motor neurons that receive signals from the brainstem. So in therapy, I use NMES equipment called Vital Stim. And I do that in combination with swallowing exercises to improve the muscle strength and coordination. So this is the console for the Vital Stim console. So you can see on the right is the operating unit, and connected there are the lead wires attached on the left to the adhesive electrodes. And those are applied to the throat in alignment with the muscle fibers to target muscle groups. There are 5 different positions along the neck, and then also we can position those in the jaw and cheeks to work on some other muscles there too. So I tell patients that performing dysphagia exercises during Vital Stim treatment is like performing a workout at double time. So we have swallowing muscles already working, but they're doing it with sensory stimulation to provide more motor facilitation at the level of the brainstem. So the way it works is basically once the electrodes are placed, patients begin to feel a series of pulses. And based on patient tolerance, the intensity of these pulses can be increased. So it's optimal to reach 80 hertz for swallowing if the patient can tolerate it, and they would be doing their individualized swallowing exercises based on the swallowing evaluation at the same time as the electrical stimulation is happening. On average, patients see improvement in 13 to 15 sessions, and those sessions are 60 minutes in length. All right, dysphagia treatment. So in addition to the conventional treatment discussed, there are also a lot of compensatory measures to address dysphagia. For example, thermal stimulation, basically the application of cold to the throat area, is one thing we can use. We also do diet alterations, and food presentation strategies are also commonly used. So based on swallowing study results, there are compensatory strategies that include completing a chin tuck prior to swallowing. And this would aid in covering the trachea to protect the airway during the swallow. So patients would just basically tuck their chin and then swallow after a chin tuck. In cases of unilateral nerve damage, or maybe a patient who's sustained a stroke, patients who turn their head to the weaker side of their body before initiating their swallow also find greater success with swallowing. So those are just kind of some examples of compensatory strategies that we use. So according to data cited in a VA report, approximately 15 million Americans have some form of dysphagia. The prevalence among those with degenerative diseases, such as Parkinson's, runs as high as 90%. Yet we're wanting to offer hope. There are some people who are simply not aware that there are treatments and techniques available to help them with their swallowing difficulties. So it's really dependent on a patient's specific situation, but there are plenty of techniques that can be utilized, as well as swallowing treatment and exercises to help strengthen and regain the ability to swallow. So at this point in the presentation, I'd like to take any questions, if anybody has any questions.
Hey, Liz, this is Dr. Vidente.
Yes.
Great presentation. Thank you.
Thank you.
Yeah. I just want to ask a few questions from my end. One is there any effect of Vital Stim on their voice?
Yes. Good point. I'm glad you brought that up. Vital Stim, we often use Vital Stim for voice improvement as well, especially in hypokinetic dysarthria, where patients have, more difficulty with the loudness of their voice. We'll use Vital Stim in those situations as well.
So in other words, you can hit two birds with one stone in patients with that type of dysarthria as well as some swallowing issues.
Correct. Yes, that's true.
What about patients with drooling with difficulty swallowing their own saliva? Is this something you will recommend?
Yes. We have quite a few patients that come in with different oral buccal, as I mentioned when we were talking about the mastication and chewing. So there's some weakness there in that, those oral muscles. And so we can also place the electrodes on the face to help with that. We get a little bit of eye twitching with that. So sometimes we have to take down the hertz a little bit. But yes, we use it for that as well.
And what exactly will the patients feel while the electrical stimulation is ongoing? Is it painful? Is it irritating? Is it ticklish? How does it feel?
Okay, yeah, that's a good question. It's kind of a sensation of like pins and needles. It's not very intense, and like it can be modulated to, the patient's tolerance level. I would say that the eye twitching is really the most annoying to patients, but that really is only when we put the electrodes on a portion of the cheek. So it's not very uncomfortable, and it really can be modulated again towards the patient's comfort level.
And then how quickly do you see results?
So what's important is to try and get at least 60 minutes of the electrical stimulation on the patient during the session. And what Vital Stim in particular recommends is to do at least 2 sessions a week. And they record results all the way up through 20 sessions. We typically have seen the most improvement in that, range of about 16.
I have many patients that undergo the Big and Loud program, both for their speech and their movements. Is this something that you recommend can be incorporated and can be done perhaps on a regular basis for patients with Parkinson's?
Yes, Absolutely. Yeah. And really it can be done along the same, at the same time as the LSVT loud exercises. So it really, can just be used really at the same time.
So you've actually done this, like doing simultaneous
Yes.
LSVT with vital stim. It's like hitting two birds with one stone, I guess, huh?
Yes, that's right. We usually have some, water on hand, and we're doing swallowing exercises and kind of alternating those kind of things as well.
And is this therapy something that can be done in their home? So do they have to visit somebody in a facility, or how is this done?
Typically, you're going in to a speech pathologist for the therapy. I've had patients ask me if they could purchase the unit on their own. I haven't had anybody do so. I'm thinking there would be regulations along those lines. So I haven't had anybody do home therapy, but with a therapist that comes into the home, it wouldn't be a problem.
In fact, that was my next question. You must have read my mind. Because not too long ago, I was mortified to hear from one of my patients who visited me maybe a couple of weeks ago, saying that, and his voice was a little better than the previous time I saw him. And he says, the trick was vital stim. And I asked him, okay, so where are you receiving the treatment? And apparently he got it, online. So they actually sold him the vital stim, and then he did some self-training. He even asked his speech pathologist in some center on how to use it. But is this something you would recommend? I mean, are there dangers of doing this on your own and learning it along the way?
I think, so when I'm more confident when I have the vital stim connected to someone, and I kind of, I'm amping up a little bit about, like, so if they're having trouble with a certain texture of when they swallow, I'm kind of amping that up a little bit more when I'm doing vital stim, and I have that confidence to do it because they're getting that stimulation. I wouldn't really have a serious concern about somebody just attaching the vital stim and doing those specific exercises. I think it's important to get the right exercises that you're practicing to really make, the most difference. So I think it's advantageous to have a therapist, oversee it for that reason. And then I would just be concerned if somebody was kind of trying to push the envelope on what the swallowing recommendation, their diet recommendations, if they were going beyond those with vital stim, I would be a little bit concerned about that.
And then there's one question from one of our attendees. How long after Parkinson's diagnosis might dysphagia typically appear?
That is so individual. Yeah, I wouldn't really be able to answer that with an average. I don't know offhand, but I would think that would be really individual to the patient.
And I would have to agree. In fact, some patients with Parkinson's may present with dysphagia in the early stages. Although I tend to see more severe dysphagia, I would say, in the typical Parkinsonian syndromes, like, for instance, progressive supranuclear palsy, or PSP. Dysphagia seems to be a very prominent issue even in the beginning. But again, it can occur in any stage of Parkinson's. Sometimes I see this also in patients in their off state. So patients with more severe Parkinson's, they now have ons and offs with their medications. Sometimes the dysphagia seems to be worse in the off state. In which case, this may be an issue, especially in the morning, when they haven't taken their first pill, and the pills help them swallow food and water, but they're really in trouble, first thing in the morning. So do you have any tips for those patients first thing in the morning before their pills take effect?
It just really depends on what their diet consistency is. Typically if it's more of difficulty with those heavier solid kind of things, sometimes by just adding more liquid into what they're eating, that softens the food and makes it a little bit easier that way.
Sure.
Yeah.
Okay, one more question from our audience. Okay. My father has advanced Parkinson's and suffered a stroke early this year. He hasn't been fed by mouth due to inability to swallow and hasn't spoken in several months. can he still get treated at this point using vital stim? And how effective will it be at this stage?
Okay, yeah. So I think the question was, how long had it been since he spoke? It was 6 months?
Stroke early this year. He hasn't been fed by mouth for several months.
Several months, okay.
Let's put some 6 months.
Okay, okay. I always start out with kind of a trial of therapy with patients in vital stim to really see what their benefits are, because what we're trying to do is some functional changes, and patients who start to see those changes and improvement are more motivated to continue the swallowing exercises. And typically we're talking about doing these exercises with a lot of frequency.
Mm-hmm.
Finding what those strategies and techniques are that work for the patient is the most important way to initiate therapy. But I would definitely try the vital stim and see, if movement could be made in diet recommendations if the patient was successful.
From your end, though, is there any difference between dysphagia from stroke versus dysphagia from Parkinson's?
As far as the results that we see, I probably couldn't categorize it based on whether it was stroke or Parkinson's. It really just is about how the patient responds. Well, I guess they are about doing their exercises too.
I guess with stroke, don't you see more of spasticity and
definitely,
in the throat, so to speak, versus Parkinson's, where there's more hypokinesis and therefore difficulty swallowing? In other words, in the different phases of swallowing, which phases are involved in stroke dysphagia versus Parkinson's dysphagia?
So we see a lot more of the earlier phases affected in Parkinson's, and then the neurological, more involuntary in patients with stroke.
Okay, excellent. I think we've answered all the questions at this point. Do you have any other parting thoughts, Liz? That was excellent.
Oh, good. I just wanted to share with you that on my last slide here, if you can still see, Melissa has offered to provide this PowerPoint to anyone interested via email. But I just wanted you to know that you can click on the last link highlighted there in orange in order to get a PDF, and it contains the statistics and descriptions and other information that I've covered in the presentation today. So.
Well, that's wonderful, because most of our attendees are actually very appreciative of slides.
Oh, good. Okay. Well, I appreciate it.